Okay, so we're going to get started. Hi, and welcome everyone to the Motherhood Center's monthly provider seminar. I'm Alexandra Woods. I'm a clinical psychologist and a therapist at the Motherhood Center, and I'm so excited to see that there was such a huge interest in this topic of sleep deprivation during the perinatal period. I prepared some materials that I'm going to review with you, and some parts I'll move more quickly to get to the most clinically useful strategies that I want to be sharing with you guys tonight. And we'll be leaving some time at the end for Q&A, so you'll see a question and answer box that you can drop questions in throughout the presentation, and then I'll address some of them at the end. So with that, I'm going to share my screen and we'll get started. All right. Here we go. So again, welcome to sleep deprivation in the perinatal period. For those who are not familiar with the Motherhood Center, we aim to effectively diagnose and treat women suffering from perinatal mood and anxiety disorders, more commonly referred to as postpartum depression. And perinatal mood and anxiety disorders, or PMADs, are a group of illnesses that affect at least 1 in 5 women during pregnancy and the postpartum period. And they also cause a number of emotional and physical problems that make it hard for women to function adequately, such as caring for themselves, their babies, or their families. So we used to think of just postpartum depression or just postpartum anxiety, but the term PMADs has really expanded to include a number of types of symptoms and to include the whole period from pregnancy through postpartum. And these are some of the illnesses that the PMADs term really encompasses now: perinatal depression, perinatal anxiety, perinatal OCD, perinatal PTSD, and postpartum psychosis. Now, what is insomnia disorder? When we talk about insomnia disorder, this covers the diagnostic criteria that would need to be met in order for a formal clinical diagnosis. So it would involve poor sleep quantity or quality, and that might include difficulty falling asleep at the beginning of the night, frequent wakenings throughout the night, and or waking up too early and having difficulty falling back to sleep. So we just call those different names based on at what point an individual would have the most difficulty sleeping. So early, middle, or late insomnia, depending on the part of the night where they experience the most sleep disturbance. In order to meet diagnostic criteria for insomnia disorder, these problems would occur at least 3 nights per week for at least 3 months, would also cause distress or impairment during the day, so cause problems in functioning. And this last criteria is really important in the perinatal period. These problems must occur with this intensity and frequency despite adequate opportunity for sleep. So there are certain parts of the perinatal phase where women don't have adequate opportunity for sleep because of some of the external sleep disruptions, which we'll talk about later in the presentation. And technically that wouldn't be considered a clinical level of insomnia disorder, but we can still treat the symptoms and the distress that they're experiencing with the same techniques and strategies that I'm going to be presenting. Insomnia symptoms are very, very widespread, with 30% of adults experiencing insomnia symptoms and up to 10% actually meeting those diagnostic criteria for insomnia disorder. And we know that women are disproportionately affected by insomnia as compared to men. So already at baseline, we're more predisposed to developing insomnia, and we're particularly vulnerable during times of reproductive transition. So insomnia disorder is more prevalent in pregnant and postpartum women than they are prevalent in the general population of women of childbearing age. And this deserves a lot more attention and research, but there's also thought to be a role of racial disparities in perinatal insomnia. The study that I cited here was looking at women of different races in pregnancy and found that Black women had a higher prevalence rate than other races, significantly higher. So there's a lot more to explore there. And we know that the effects of insomnia are very bad for both mom and baby. Insomnia in pregnancy is associated with a host of negative outcomes, including preterm birth, gestational diabetes, and maternal psychiatric illness. And it's thought that changes in sleep physiology and sleep deprivation may play a role in the development of perinatal psychiatric disorders. The good news is that insomnia treatment in pregnancy may reduce some of those PMAD symptoms. The study that I cited here was looking at the relationship between insomnia intervention in pregnancy and postpartum depression symptoms as the outcome. But the insomnia treatment that they were studying was specifically medication interventions. So I think that there's still some room to look at CBT for insomnia as a predictor of reduced PMAD symptoms. Before I introduce some of the cognitive and behavioral strategies that I'm going to be sharing with you tonight, I did want to say a word about medications for sleep in the perinatal period. I will say that I'm not a prescriber, and that's not going to be the focus of the presentation tonight, but I did want to give a couple of bullet points from a really great review article by Chaudhry and Susser, and sort of give you some of the takeaways, which are that it's really non-pharmacological interventions that are considered the primary intervention for perinatal insomnia, and they're considered to be very effective, which I'll review in the next couple of slides. But there are some who are at risk for psychiatric illness in the perinatal period who do require medication. Generally, a lot of the safety data for benzos, antihistamines, and sedative hypnotics are reassuring, but some studies do show associations with poor outcomes, and there's some limited data on the safety of trazodone and melatonin. And before we get into some of the other phases of the perinatal period, I really wanted to talk about sleep protection when you have a newborn. So when you have a little baby who, in the first few weeks, they haven't yet established their circadian rhythm. They've been in the womb where they haven't yet been exposed to light and dark, and they really haven't developed a consistent circadian rhythm. So they don't, for the first 8 weeks or so, really know the difference between day and night. They also need to feed every 2 to 3 hours around the clock, including overnight. So what's tricky is that some of the ideal practices for breastfeeding initiation are in conflict with ideal sleep practices for preventing a PMAD. What we recommend is having a 5-hour shift-based schedule for overnight feeds, where you and your partner or a support person can divide up the night into 5-hour shifts, and one person is in charge of tending to baby's needs during that stretch of time so that the other can get an adequate stretch of consolidated sleep. And we believe that 5 hours as the minimum goal is what you need to protect against a PMAD episode. So that said, this may look a little bit different if you're exclusively breastfeeding. If you are nursing and need to develop a shift-based schedule like this, it would involve the partner or the support person bringing the baby during any night wakings to the breastfeeding mother while she stays in bed, nursing and doing that feed while waking as little as possible. And then the support person can take the baby and do any diaper changes or settle the baby back to sleep, and therefore allowing the nursing mom to just get as much sleep and as much uninterrupted rest as possible during her 5-hour shift. And, this is a time when you might need to think about priorities and how you're going to sort of balance your breastfeeding needs with your need for consolidated sleep. and work with a lactation consultant or your pediatrician to figure out what's possible so that you can get longer and longer stretches of time for consolidated sleep. At around the 4-week time point, once the milk supply has really been more established, it may be a good time to start introducing a bottle so that the partner or support person can take care of a night feed without waking the mom and without affecting that breastfeeding relationship. But this is a time when you might have to make some choices based on what the priority is. If your patient is at high risk for developing a PMAD, we highly recommend really protecting that 5-hour stretch of sleep and thinking about what the priority is. And others may choose to prioritize breastfeeding and know that it's a sort of time-limited period when they're going to be needing to do those round-the-clock feeds. So I'm going to now talk about CBT for perinatal insomnia. First, pregnant women prefer CBTI over medications. The outcome research shows that it's highly, highly effective. So treatment response rates are around 70 to 80%, which is incredible for a psychological intervention. I mean, think about, outcomes for depression and anxiety treatments, which are so much more complicated. We really understand how sleep works. And so CBTI, gives an incredibly positive response. And remission rates average around 50% with treatment gains maintained over time. So I believe that this review article was looking at outcomes followed up to 2 years after being treated with CBTI, and patients had really maintained those gains and those improvements in their sleep even years after. And we know that it's effective in both face-to-face and digital formats, which is great since so much of our work these days is being done virtually. So before I start to introduce some of the specific strategies, these are some of the foundational psychoeducational information that I share with patients and that are so important for understanding some of the CBTI recommendations. So what you see here is what we call the 3P model of insomnia. And this is sort of the classic image that's shown. There's basically 3 categories of factors that contribute to the development of insomnia. On this axis, you're going to see different phases of insomnia, from pre-morbid to acute to early through chronic. And on this axis, this dotted line shows the threshold for a clinical level of insomnia. Now, I'm going to start with predisposing factors. Predisposing factors are things that make us more or less vulnerable to developing insomnia at our baseline, and they vary from person to person. So they might include, biological factors. Someone might have a family history of insomnia, might be more sensitive to disruptions in their sleep environment. Premorbid factors might involve personality characteristics that make someone more likely to develop a sleep problem. These are sort of the things that are, at our starting point, make us more or less vulnerable, make us closer or further from hitting this threshold for insomnia. And you'll see that from the premorbid phase all the way through chronic, the pink part of the bar, those predisposing factors, they don't change. They just sort of stay the same. They're the thing that all the other factors build on top of. Now, as we move into acute insomnia, you'll see that there's blue bar that's been added on top, and that's what we call precipitating factors. And precipitating factors are things that trigger our insomnia in this particular moment. So that may be, for example, you have a big deadline coming up for work and you're really anxious about it, or, you're having an argument with your partner. The kinds of things that come up, day-to-day stressors that might, give us a sleepless night or a sleepless week. And so that piles on top, and in acute insomnia, it's the precipitating factor that actually pushes us over the threshold. In early insomnia, you'll see that now we have a third layer of factors that are contributing to the insomnia, and those are what we call perpetuating factors. And perpetuating factors are the things that we do, the habits that we develop, that help us get through the day when we've had a poor night's sleep or few poor nights of sleep, and they help us in the moment to function, but they actually end up maintaining the insomnia and fueling it going forward. So these might be things like, drinking that extra cup of coffee, taking a nap. They're things that, again, might feel really helpful and adaptive in the moment, but then cause us to have a sleep problem the next night. And as we move into chronic insomnia, you'll see, predisposing factors, the pink bar stays exactly the same as always. Now the precipitating factors over time have actually subsided. Maybe like the argument with your spouse was resolved, or that work deadline passed, and that's no longer causing the insomnia. It's really at this stage the perpetuating factors that keep us above that threshold. So there are so many factors that are specific to the perinatal period. And this just lists some of them, but these are basically summarizing the 3 Ps of the perinatal period. Predisposing factors, as I've said, just being female makes me more vulnerable to developing insomnia. Having higher levels of physical and cognitive arousal, personality variables, hormonal changes is a big one. In the first trimester of pregnancy, your progesterone levels shoot way up and make us feel extra, extra sleepy. And after we give birth, those levels plummet and can make us feel really wired. And so, and hormonal changes, even just during our usual menstrual cycles and things like that, can really have an impact on our sleep. And of course, as I mentioned, also anxiety and depression. Precipitating factors during the perinatal period include often positional discomfort in pregnancy. Your body's changing. Maybe you're typically a back sleeper, and now you have to figure out how to stay sleeping on your side. Joint or back pain. The pregnancy period is a time where women have a higher rate of restless leg syndrome, which can be very uncomfortable during the night. Nocturia refers to frequent use of the bathroom during the night, having to urinate a lot and get up for that. And then once the baby comes, you have nighttime infant care, and often, hypervigilance at night. You're sleeping, but you're sort of staying in this like very light stage of sleep because you're constantly listening to hear if the baby's waking. And so all these things can be triggers in that acute phase of insomnia. And then these are some of the many perpetuating factors that tend to develop during this time. Long periods awake in bed, maybe napping during the day. Everyone always says, nap, sleep when the baby sleeps. So daytime napping can sometimes fuel nighttime insomnia. Little exposure to daytime bright light, like if you're inside a lot, which many of us are these days, and you're not getting out an exposure to bright light, that could play a role in disrupting the circadian rhythm, and disrupted physical activity patterns can also play a role. The good news is that we can actually change and modify these perpetuating factors so that short-term insomnia during the perinatal period triggered by these precipitating factors do not develop into a long-term chronic problem. And that's really the foundation for CBTI. We're going to say, okay, everybody comes in with some predisposing factors, and there's some precipitating factors that are out of our control right now, but they're temporary. We're going to focus on what we can control, which is making sure that our sleep hygiene and some other strategies that I'm going to introduce, that those things are really tight so that our short-term sleep disruption doesn't become a long-term chronic disorder. This is also something that I share with patients when I'm introducing CBTI, because it's so important for them to understand how the recommendations for behavioral changes are linked to our understanding of how sleep works. And it can be very motivating for them to get some of this education in advance. So this image shows the two processes that regulate our sleep. And this is showing a 24-hour span of time from 9 a.m. on one day to 9 a.m. the following day. And the first process is called the homeostatic sleep drive. And I sort of explain this by comparing it to hunger. The longer that we go without eating during the day, the hungrier that we get. And if you wanted to be really hungry at dinner time, you wouldn't eat like a big snack or junk food before dinner. It would spoil your appetite. And the same is true for our sleep. When we wake up in the morning over here at at 9 a.m., we've filled up our sleep bank, and our sleep drive starts out very low. And as we move through the day, we're active, we build that drive, that hunger for sleep. And if we want to be sleepy at bedtime and have it really peak around our desired bedtime, then we don't want to take naps or drink a lot of caffeine that's going to be stimulating. We don't want to do things that interrupt the building of an adequate sleep drive. It would be the same as eating that junk food and spoiling our appetite for sleep. So that's sort of how the sleep drive works. And the circadian rhythm is the other process that regulates our sleep. And it is moderated or regulated by cues from light and dark. So in the evening, when the sun goes down, our body releases melatonin, which is a naturally occurring hormone in our bodies, and melatonin makes us feel sleepy. In the morning, when we're exposed to bright light, it suppresses melatonin and it makes us feel alert for the day. So there's also some sleep hygiene recommendations that are tied to this, where we want to get bright light exposure during the daytime hours to sort of signal to that sleep-wake center in our brain that, hey, it's time to wake up and to be active. And then in the evening, we really want to create good conditions for ourselves where we turn off electronic screens and we dim the lights and we reduce our bright light exposure so that we can release melatonin and start that process where we begin to feel sleepy. So both of these processes are really important. And as you see in this chart, they sort of have to sync up in order to produce good, healthy sleep. And these things really operate on a rhythm, and consistency is so important. So these are some of the sleep hygiene recommendations that I provide patients with for the daytime, because there's going to be a set of daytime behaviors that we target and a set of nighttime behaviors. And these are the things that we want to pay attention to during the day. The first is to establish a regular wake-up time and routine. So many people focus on bedtime when they set goals around their sleep, but it's actually the wake time that becomes so important, because we can't always control if and when we feel sleepy in the evening, but we can always control when we wake up and when we hit the reset button and start to build our sleep drive throughout the day. And if that start time varies widely day to day, then it really messes with that consistent rhythm. You also, as I've said already, want to get exposure to bright light as early as you can after waking, and sunlight is best. So, encourage patients when they wake up and they feel that inertia, like it's hard to get momentum and to get moving in the morning, go right to the window, open the shades, and get that blast of sunlight that's going to help them to wake up and signal to their body that it's time to be alert. You also want to avoid or at least limit caffeine intake. Everybody's body processes caffeine differently, but for some, it can be in your system for up to 12 hours. So you really want patients to think about setting a deadline for themselves. I'm not going to have coffee after 11 a.m. or, whatever they want that cutoff to be. And to also remember that sometimes caffeine sneaks into things that we eat or drink that we don't realize, and is sometimes in medications like Excedrin and things that we might not even realize. So to just be aware of how many caffeinated beverages and whether there might be caffeine in other things, chocolate, for example. You also want to encourage patients to develop an exercise routine. It doesn't necessarily have to be like intensive exercise, but it's so important to stay active, because again, we want to build that sleep drive, and moving our body is such an important part of it feeling tired at the end of the day. So especially these days, it's winter, we're all staying home more. It's really can be difficult with a new baby to get moving and to find pockets of time for that. But if you can encourage them to figure out how to, go take the stroller for a walk, or, do a streaming exercise class, if they have pockets of time, it's so important to make sure, if we're sedentary all day, we just don't build adequate sleep drive for the night. And then finally, consider limiting daytime naps if you're having trouble with nighttime sleep. So like I said before, naps we can kind of consider as the snack that spoils your sleep appetite. So if the patient is having difficulty sleeping through the night, and it's not because of baby waking up or some external disruption, but it's real insomnia, then you may recommend that they limit their daytime naps so that they can consolidate that sleep in the evening. And I'll say if somebody is not having trouble with nighttime sleep, they're sleeping solidly through the windows of opportunity that they get for sleep, but it's just not enough, then go ahead and take those naps when the baby's napping. Now, these are some of the sleep hygiene recommendations that target bedtime before bed. So first is develop a pre-bedtime routine. This seems like something that we know to do for our kids, but sometimes forget to do for ourselves. And it's so important to really prepare your body for a restful night, and to have some buffer time between the activities and the stresses of the day and when you get into your bed to sleep. So I really encourage, even if it's brief, for patients to develop some kind of routine that's soothing and relaxing to them. It might include taking a bath, it might include an audiobook or a meditation app. It might, you can help them be creative about what it involves, and it could be very simple and brief, but some kind of bedtime routine to separate the day from the nighttime. And ideally, that routine would involve putting their screens down. Like I said earlier, our circadian rhythm is regulated by cues of light and dark. So when we have exposure to screens, it really can confuse those sleep-wake signals, especially the blue light from the electronic screens. So ideally, they would have a 60-minute buffer without screen time before bed. But if you can even encourage 10 minutes, a half an hour, it's really important, and such a common habit for people to be kind of scrolling on their phones in bed or watching TV right until they fall asleep. So see if that might be something you could set a goal around. For some women, and especially during pregnancy, or if you're breastfeeding, it may be helpful to have a light snack before bed so that you don't wake up during the night when your blood sugar drops and wake up hungry during the night. Just think about what snacks make the most sense for you to have at that hour. So, something light, not something that's going to be heavy and difficult to digest, maybe a banana or some crackers, or, a piece of cheese. You also want to avoid alcohol after dinner. So there's a really common misconception that alcohol helps you sleep, and it is a hypnotic, which means that it helps you to fall asleep at the beginning of the night, but it actually will disrupt your sleep as it's processed in your body. So we really like to limit alcohol after dinner and skip that nightcap. And the last tip here is to turn the alarm clock around. So if you have anxious patients who are clock watchers, this is a really helpful technique, is just to take the pressure off, instead of watching the minutes tick by and becoming increasingly frustrated, or doing that countdown that we've all done before. Oh, now I'm only going to have 4 more hours to sleep. Now it's only 3.5, and feeling that building sense of urgency. Just turn the alarm clock around and don't check what time it is. Treat a night waking the same if it happens at midnight and you have the whole night ahead of you, or if it happens at 4 a.m. and you might only have an hour or two left to your night. Okay, so now these next few slides are going to transition from the sleep hygiene recommendations to two of the behavioral sleep interventions that have actually been shown to drive many of the outcomes in the CBTI research. So these sleep restriction and stimulus control are what is believed to really cause the most improvement in sleep outcomes. So sleep restriction is sort of built on the idea that everybody's body has a particular sleep need. And it ranges, it's typically, between 7 and 9 hours, but it changes throughout different phases of your life, and it's really different person to person. And the problem is that many times patients who have insomnia will tend to overextend the amount of time that they spend in bed in order to overcompensate for a poor night's sleep. The problem is that if you only need 6 hours of sleep, but you're laying in bed for 10 hours, your sleep becomes disrupted. It becomes broken. And it's just not as restorative as getting 6 solid hours that are uninterrupted. The metaphor that I really like for this is if you were going to bake brownies and you had like a ball of dough, but your pan was like huge, you were spreading the dough over this like huge pan, then your brownie would be broken. It would be thin, it would burn. But if you have a pan that actually fits the amount of dough that you have, then you get a nice consolidated brownie. And that's what you want with your sleep. You want it to be thick, consolidated, and uninterrupted, not broken. So what we do is we actually shorten the amount of time spent in bed to meet the amount of time that the patient's actually sleeping. So for example, if the patient's typically only sleeping 6 hours, but they're laying in bed for 8 or 10, we're actually going to prescribe a shorter window, a restricted window of only 6 hours. And then we track it over time and we calculate what we call their sleep efficiency. And the sleep efficiency is the ratio of total sleep that they actually get divided by the amount of time that they spend in bed times 100. That gives you a percentage. So for example, if they're sleeping 6 hours, but they're spending 12 in bed, that's only a 50% sleep efficiency. That's really low. Our goal is 85%. So we shrink it down to meet their actual sleep need based on sleep diaries and logging that you'll do with them. Once 85% sleep efficiency has been achieved for at least a week, then you can slowly increase the window of time that they spend in bed by about 20 minutes. And you'll do this over several weeks. You'll know when you went too far because the sleep efficiency will drop. Once you stretch and extend that time in bed too much and their quality goes down, then you're gonna set it back by 20 minutes to the last week that you got 85% sleep efficiency, and you lock that window in, and you know that that's the right window for them. So these are some things to consider when you're doing sleep restriction. I always set patients' expectations that they're gonna feel really tired at the beginning of this. You're actually, your body for those first couple nights hasn't yet learned that it's not gonna get the nap, it's not gonna get to sleep in if it doesn't get the sleep during your desired window. So you might still have broken, non-consolidated sleep. If you feel tired during the day, that means that it's working. And by night 2, 3, 4, your body will have built a super strong sleep drive to actually crash through those hours that you do give opportunity for sleep. And if they really maintain, the rules around this, and they don't take naps during the day and they don't sleep outside of that prescribed window, then we expect that by around night 3, they're going to crash when their head hits the pillow at their prescribed time. And that's when you can kind of reset their whole sleep rhythm. But they have to sort of power through those first few days, which are often really difficult for people. And that's, again, why some of the psychoeducation and the education about how sleep works becomes so critical for motivation. To prevent excessive daytime sleepiness, we don't really restrict to less than 5 hours per night. So again, 5 hours is that sort of minimum stretch of time that you want to give. And we don't recommend sleep restriction if your patient has bipolar disorder, because we don't want to trigger a manic episode through the sleep restriction, or if they have safety concerns about excessive daytime sleepiness. So if your patient's really worried that they're, not going to be able to safely provide care for their baby, or, if they have to drive, if they're commuting to work or something, then you really wouldn't want to do sleep restriction. So the second behavioral intervention is called stimulus control. And some of you may remember from your intro to psych class, Pavlov's dogs. And Pavlov was this Russian researcher who was interested in studying salivary glands. And what he would do is he had dogs in his study, and he would ring a bell and present them with meat powder. And he would do this over and over again, bell, meat powder, bell, meat powder. And the dogs who would salivate when they were fed started to associate the bell with, I'm about to get dinner, and they would salivate even at the sound of the bell when there was no meat powder present. So the idea here is that the bell became a stimulus that triggered a physiological response in their body. And the same is true for us with our bed. The bed, we want to be a strong stimulus for your body to sleep and to get sleepy. And in order for us to build this association, we need to repeatedly pair bed, sleep, bed, sleep, bed, sleep. So to strengthen that association, that means we need to get any non-sleeping activities out of the bed, and ideally out of the bedroom. That means, no doing your bills in bed, no studying in bed, no watching TV in bed, or even reading. We only want the bed to be used for sleep and sex. That also means that we want any wakefulness out of the bed, so not just activities, but like tossing and turning or feeling anxious. We don't want that to be associated with the bed. So what we recommend is when someone's in bed and they're having difficulty falling asleep, let's say it's been 15 minutes and just isn't happening for me right now, we want you to get out of your bed, do a non-stimulating activity for 10-15 minutes, and return to bed when you're ready to give it another try, which can either be after a certain amount of time, set a timer and come back again in 10-15 minutes, or it could be based on when you recognize those sleepy cues and feel like you're ready to kind of give it another shot. And then you repeat that procedure as often as necessary. If you get back into bed and you're still having trouble falling asleep, we want you to get up again, continue that non-stimulating activity, nothing with screens, and then come back and give it another try. And then similar to sleep restriction, we want you to get up at the same time every morning, again, to reset that sleep drive for the following day. So here are some of the considerations for stimulus control. You want to help patients find activities to engage in when they get out of bed. So these should be things like doing a crossword puzzle, or reading a book, listening to a podcast, folding laundry. Nothing that's going to be too stimulating or activating during the night, but something either soothing, repetitive, and have a list of things in advance that they're going to do. And again, something that's not using an electronic screen, because we don't want to confuse those sleep-wake signals. And you want to identify cues to determine sleepiness and time to return to bed. Because the same way that we want the bed to be strongly associated with sleep, we don't want other spots in the house to be associated with sleep. We don't want them to fall asleep on the couch and then have the couch be a place that they're body associates with sleep. And you can also get creative as needed. I know, many of our patients may live in small apartments or, not have another space to go to. And so you can modify this, like even if they have a chair that's next to their bed, or they sit up at the foot of their bed, not in the space where they actually go to sleep. Making those small distinctions really helps your body say, okay, this is where I unwind and this is where I do other things. You want to use an alarm clock to maintain that regular rising time. And you want to find competing activities to fight the urge to take a nap during the day. This goes for both sleep restriction and stimulus control. During the day, you really don't want them to doze off and really undermine that sleep drive that you want to build throughout the day. If they're feeling really sleepy before their prescribed time, help them think about what's another activity that you can do that's going to prevent you from dozing off. And it might involve pacing your activity level or changing their timing. So like if every day at 3 o'clock they feel like they're in a slump, and that's a time when they're likely to take a quick nap or doze off, that, you want to change that up and say, okay, well, what can we do at 3 o'clock? 3 o'clock is the new time that you're going to like go on a walk, or you're going to like go stand and do the dishes, or like do something where you can't fall asleep. So now I'm going to move into the last strategy that I'm going to provide from CBTI, and that is the cognitive part of CBT. We've been talking a lot about behavioral changes that we recommend to patients and behavioral habits, and this is a different set of tools that is really effective, and that's challenging anxious thoughts about sleep. So on this side of the slide, we have this cycle. This is the cognitive model of insomnia. Essentially, we have a poor night's sleep, and then we say to ourselves, "Ugh, I'm never going to be able to function tomorrow. It's going to be a terrible day." We get frustrated, we feel anxious, and that anxiety is really activating. It triggers that stress response in our body, the muscle tension, the heart racing, all the things that are really incompatible with getting a restful night of sleep. So it ends up actually contributing to your insomnia. And then as a result, we, feel sluggish the next day. We blame the bad night's sleep from the night before, and it starts the whole thing over again. So there's different spots where we could really target our intervention. And when we think about the cognitive intervention, we're going to really go for those maladaptive thoughts about sleep. So for example, the idea that I'll never be able to function tomorrow. And this is where you're going to use some of your CBT strategies around cognitive restructuring to help the patient challenge that and come up with an alternative that's a little bit more helpful for them. So for example, you might ask, okay, there's lots of nights where you have been sleepless or you haven't gotten as much sleep as you wanted to. Have you been able to function adequately, or at least, kind of get through the day and do the things that you needed to do? Is every time that you have a bad night's sleep result in a terrible, awful day? Or, when someone's blaming the bad night's sleep for their bad day, that might be a moment to say, to sort of challenge the idea that their sleep is the only thing that impacts how they feel during the day. So, this is where I might draw a little pie chart and say, how much of the pie do we attribute to sleep when it comes to how we feel during the day? And often my insomnia patients put sleep as, it's the entire pie. And then when we really talk it through and we sort of add in other factors that contribute to how we feel during the day, they start to acknowledge, my activity level affects how I feel, how much energy I have. My diet affects how I feel. The state of my relationships or how stressed I feel about work or other things. Yeah, I guess there are some other things that actually play a role. It's not just sleep. And we sort of come up with a more balanced appraisal rather than over attribute the role of sleep in how we feel during the day. So those are some examples. And there's a really great assessment tool that is called Dysfunctional Beliefs and Attitudes About Sleep. I have it listed on another slide for you guys, but it really helps you to identify some of the big ticket items that you could target with cognitive restructuring in this way. And some of the themes, these are actual items from the scale where someone would, rate from like 1 to 5 or something, how much they agree with this statement. And so some of the themes that I see the most are, I need 8 hours of sleep to function well during the day. People get really stuck on a certain number that they think that they need. Or I have limited ability to manage the negative consequences of poor sleep. They feel inadequate, incapable of sort of managing how they might feel the next day. Or they think, medication is probably the only solution to my sleeplessness. They sort of discount all the perpetuating factors that we've been talking about tonight, and sort of minimize the impact of all of these behavioral interventions that we know to play such a big role. Or I avoid or cancel obligations after a poor night's sleep. That might be something that you want to help the patient to challenge, that they're not able to participate in the things that are important to them because they feel sleepy. So these are some of the common themes and the things that you might sort of prepare in advance. And so again, the goal is to reevaluate their anxious thoughts and generate more adaptive responses. And these are some of the things, the responses that you might want to help guide the patient to conclude. Things like, there's no gold standard of sleep to function, right? Like, there's nothing magical about 8 hours, for instance. Or, I've functioned adequately with little sleep in the past. Like, sure, those aren't my favorite days. Maybe I don't feel like I'm functioning at my top at 100%, but like, I can sort of get through it and do the things that I need to do. That there are, like I just said before, that there are many factors that affect how I feel during the day. It's not only sleep and sleep alone that contributes to how I feel. And really importantly, that I do have some control over my sleep. And hopefully by the point in treatment that you get to some of these cognitive strategies, you have them already implementing some of the behavioral changes, and they start to actually see how it does impact their sleep, and how there is so much that is in our control that we can do to create the best possible conditions for ourselves. So again, these are just some of the alternative responses that you want to help them to generate through that cognitive restructuring process. These are some of the assessment tools that I use to guide treatment. I always, when I do CBTI, it is a requirement that they complete sleep diaries throughout the whole treatment so that we can really monitor and log how things are going, that we can figure out what's important for us to target and see how the changes that we're making are actually translating into how they sleep. And, I always tell them I'm much more interested in your perception of how you slept rather than like knowing that it was exactly 17 minutes for you to fall asleep, right? Because we don't want to cause more anxiety and clock watching. The Insomnia Severity Index is a really great 7-item screener for insomnia that can provide sort of an objective snapshot of how they are doing at the beginning, middle, and end of treatment. Or you can even do it in every session if you want to track it more closely. Dysfunctional Beliefs and Attitudes About Sleep is that measure that I just mentioned a couple of slides ago that can really help you with the cognitive restructuring and figuring out what are some of the maladaptive beliefs and cognitions that are fueling their anxiety. Measures of fatigue and sleepiness, such as the Epworth Sleepiness Scale, might be helpful. Sometimes people feel really exhausted, but it's not necessarily sleepiness. It's not that they, if they close their eyes, that they would fall asleep. In fact, often insomnia patients say, like, I can't nap during the day. I wish that I could. I feel this general malaise and fatigue, but that's a little bit different than sleepy. The stop bang is an assessment for sleep apnea, which is disordered breathing when you have an obstructed airway, which can sometimes happen, just during pregnancy with weight changes or just structural, the way that your airway is structured. Sometimes women during the perinatal period can be at higher risk for sleep apnea. So you might want to do one of these quick stop bang assessments to see if you might want to refer for a sleep study, and measures of mood and anxiety, because it's really interesting to see how improvements in sleep are associated with those improvements in mood and anxiety symptoms. And these are some resources that you might find helpful should you want to learn more. The book, Behavioral Treatments for Sleep Disorders, is just an amazing resource. It has interventions that go beyond CBT for insomnia. It also talks about other sleep disorders, but it's really great in overview of the research, but also can be sort of used as like a treatment manual almost, if you're working clinically and want more detail about how to implement some of these strategies. And the Women's Guide to Overcoming Insomnia is really great because it, as we've done tonight, sort of highlights some of the cognitive and behavioral strategies that are most helpful to adapt and apply during the perinatal period, and can help us understand also just how hormonal changes impact our sleep at different reproductive stages. So I really like this resource as well. So I am also another resource for you guys if you're a provider who is working with someone that has perinatal insomnia. I often collaborate with someone's ongoing therapist where you can continue to work on depression or anxiety or other symptoms, and without interrupting treatment, we can add CBTI as an adjunct to the work that you're doing, and that way it doesn't really interrupt the work that you're doing together, but just adds someone with some expertise to really target the sleep problem simultaneously. So please do give us a call if you think that you have a patient who might benefit from some extra support around your sleep. And in addition, the Motherhood Center has really wonderful virtual support groups with some really great themes here. PMAD support group, pregnancy support, perinatal loss, having a second baby after a PMAD, and our Mothers of Color support group. So you can go to this link to look for more information on those. These are some of the references that I used to put this presentation together, and you can take a look at these more closely because you'll be getting the slides following the presentation. And if you would like any additional information or want to follow up with us, please contact us at either our main line or our email address. And we have a couple minutes left for questions. So I'm just going to take a quick look to see what questions have come in. Okay, this is a great one. So do the 5-hour stretches have to be at night to be effective? A lot of people, especially single moms, may have more access to support during the day rather than overnight. But in general, night sleep is usually better quality. You're absolutely right. So the 5-hour stretch does not need to be at night. I always tell patients during a, actually, let me stop the screen share. I always tell patients that whenever you're able to get the most support during a 24-hour stretch, if you have a friend or your mom or someone who can come over during the day, take that 5-hour stretch in the middle of the day. Do it whenever you can get it in. Night sleep is better if you can get it, just because of our circadian rhythm and wanting to maintain some consistency in our sleep schedule. But It does not have to be at night. Let's see what else. What are some ways to help patients avoid taking naps when they're feeling exhausted during the day? This is a great question, and I really recommend brainstorming this with patients. I always think that doing something physical is going to be the most effective at preventing dozing and taking naps. You know, if your strategy for avoiding naps is to sit on the couch and read a book, like you're likely to fall asleep. But if you're doing something, moving your body, you're less likely to doze off. So, you know, that's a time when I say get up and take a walk, have that be the time when you exercise. I know that it sounds counterintuitive to do something that requires the most energy at the time when you feel the most sleepy, but that is actually the best way to keep you from falling asleep, or to do some of those physical household chores, you know, wash the dishes, wash the bottles, fold the laundry, do things where you have to kind of get moving. Let's see. So one of the questions here is about the order of the interventions for CBTI. And you can certainly kind of pick and choose certain components that feel like they're going to be most helpful for your patient. But typically CBTI, the order is sort of how I presented the slides. So you'll start with education about sleep, sleep hygiene recommendations, then you'll move into the behavioral components, which are sleep restriction and stimulus control. And like I mentioned briefly before, these are the interventions that are the components of CBTI that have been found to really drive the outcomes more than the other parts. So most people, you know, sleep hygiene alone may not result in remission of your insomnia, but the sleep restriction and stimulus control often do. And then conclude with the cognitive strategies, because really, you know, you can do some targeting of those anxious thoughts, but once you start to make the behavioral changes, that's really when you can be more effective at challenging the anxiety. You know, someone's done sleep restriction and then you start to target thoughts about functioning the next day. You can kind of look back to, you know, last week we restricted your sleep window and, you know, you still got through the day. So it kind of like provides you with some of the material and some of the evidence that you need to do some good cognitive restructuring. So you know, sometimes you need to bring in some anxiety management techniques earlier in the treatment, but I usually do follow that structure. Let's see what else I can quickly answer. So one of the questions is about other anxiety management strategies. And so really quick, and this is for when the anxiety is not about sleep. One of the things that you can introduce is a set of, you know, relaxation strategies that, as we said in that cognitive model, the anxiety itself is very activating and can end up fueling the insomnia, because, you know, it activates your stress response and causes all this physiological arousal during the night. And so, you know, introducing some techniques like deep breathing and progressive muscle relaxation, and you know, visual imagery to, you know, imagine themselves in a soothing, relaxing place and, you know, start to feel those physical effects can be helpful. And another tip that I like to give is to just put a pad of paper and a pen next to your bed. And when you have something that you're ruminating about, or that you find yourself getting really stuck thinking about, just jot it down, externalize it, get it out of your head and onto a piece of paper. And it might sound kind of silly, but schedule worry time to come back and address that anxious thought the next day. Because I had a supervisor once who said that, you may not be sleeping at night, but reason is asleep. And so nighttime is usually not a great time for us to be problem solving, or taking action on any of the things that are making us feel anxious. And so putting it aside and saying, I'm going to come back to that and really honor it tomorrow, can be a helpful way for us to kind of let go of the rumination, and get some rest. So with that, we've come to time. I'm so sorry for the questions that I didn't get to, but I hope that this was really helpful, and that you can take some of the strategies and the tips that you learned here and use them to help our patients who are in so much need during this phase of their life. So thank you so much, and take care, everyone. Have a good night.